Letting me do this. I'm really excited to be here. I too am, since I've been in dermatology for the last 13 years, I'm relearning a lot. You know, I haven't had a stethoscope around my neck for about 13 years, so I'm having to review a lot. I was a dietitian before that. I graduated from the OU Health Sciences Center as a clinical dietitian, worked for 3 years in Dallas at the Dallas County Hospital, Parkland, and worked primarily in nutrition support, so people who were being fed via tube or IV nutrition. And then I decided to go back to school and came back here and graduated from OU PA program. Another couple of things, I'm married. It will have been 23 years this summer, and I have just one daughter who's 17. She will be a senior at Bishop McGuinness this next year, and so in about a year from now, if you see me crying in my office, I'm going to be so emotional and sad when she goes on to college. So if you see me boohooing like a big baby, you just say, "Oh, that's Amy. She's just acting a fool." So, so forgive me, because I know I will be a bit emotional during this time. But so we'll go ahead and talk about diabetes and the skin. You know, as you are learning, or will learn, diabetes affects so many parts of the body. Skin is the biggest organ of the body, so no surprise that it affects the skin as well. There are a number of factors that we know, complication of, or parts of diabetes, complications of diabetes, and how it affects the skin, such as hyperglycemia, hyper and hypoinsulinemia, hyperlipidemia, the progressive changes to the vascular, neurological, and immune system, and then there are some correlations that we just don't know, why we see some of the skin conditions more in diabetics than others. So hyperglycemia, we know that when we have high blood sugar levels, that this leads to a particular type of metabolism, I'll call it, called non-enzymatic glycosylation, all right? This occurs in everybody as we get older, but it's much more marked in diabetics. And that leads to an increased number of these AGEs, or advanced glycation end products. Then you have this enzymatic digestion of collagen, all right? And this collagen tends to collects in the skin. This breakdown of the collagen tends to collect in the skin and the periarticular subcutaneous tissue, so the tissues around the joints, especially in the hands. So this type, we know, is associated with what we call diabetic thick skin and joint immobility. One important thing, and we'll talk more about all these conditions, but this correlates strongly with the smaller vascular and sensory changes, such as retinopathy, neuropathy, as well as nephropathy, which I don't have in there. All right, we also know hyperglycemia will change our immune system, especially if a person is in a state of ketoacidosis. Our white blood cells do not behave the same. They don't have as good bactericidal properties. So therefore, diabetics, when they are out of control, especially in states of ketoacidosis, are at much greater risk of infection. There are certain infections that we'll talk about that they are extra prone to. All diabetics are prone to. Hyperinsulin levels, we know, will attach onto insulin-like growth receptor factor 1, which mediates this abnormal epidermal proliferation. So the epidermis, the epidermal cells proliferate in states of hyperinsulin. The opposite, insulin deficiency, we have encourages, well, the LPL, or the lipoprotein lipase, doesn't work as well in states of insulin deficiency. So when that occurs, our bodies are not able to process those triglyceride-rich chylomicrons and the VLDLs, and therefore you get these states of hyperlipidemia, and sometimes they can be drastic, especially the triglyceride levels. Diabetics almost always have elevated triglyceride levels, so we'll talk more about that. And then, of course, that when you have high lipid levels, that plays along with the vasculopathies in the small and larger vessels. All right, so certain conditions that we know kind of what they're related to. Acanthosis nigricans, the diabetic thick skin, and limited joint mobility, eruptive xanthomas, cutaneous infections, and diabetic ulcers. All right, acanthosis nigricans. Anybody heard of that? Oh, good. Did you guys talk about it in some excellent? You will see this a lot, I promise you. So we know this is linked to insulin resistance, high insulin levels, and obesity. So when you see somebody with acanthosis nigricans, automatically think, are they diabetic, number one, or are they pre-diabetic? Now, there are some occasions that it's not related to pre-diabetes or insulin resistance, but the large majority will be. You're going to see this higher in African American, Latino, and Native Americans versus the Caucasian population. It has been stated as a marker for malignancy. That is very rare. The only time you're really going to think about that is if you have a person who presents who doesn't fit the other criteria. They're not diabetic, they're not obese, they're not pre-diabetic, and they have just a very florid case of acanthosis nigricans. Then you might want to consider doing have you had your well maintenance or health maintenance checks. And just FYI, it's most often GI malignancies, especially the stomach. Okay, so insulin resistance is a key factor. Okay, so this excess insulin binds to that IGF-1 receptor, and this causes the keratinocytes on the epidermis to proliferate, to reproduce at greater amounts, as well as the dermal fibroblasts. So when you're talking about, and I always try to emphasize, when you're talking about the epidermis, that's the top layer of the skin. When you have involvement there, you're gonna see it more in the form of scale, thickening of the skin, that sort of a thing. So versus when something is occurring deeper in the skin, it tends to kind of lift the tissue up rather than causing scale and things like that. The next statement really is not that important. My point with that was just that there are a couple other occasions when you may see acanthosis nigricans that's not associated with prediabetes, and also there's some medications that can induce acanthosis nigricans, so you might just keep that in the back of your head. All right, so what does it look like? The clinical findings, again, you may not be real familiar with the dermatological terminology. So I'll try to explain it as we go along. So symmetric, it's on both sides of the body. If it's here, it's usually here. Hyperpigmented, it's darker. Velvety to papillomatous. Papillomatous is kind of a term, kind of bumpy and almost warty-like, okay? Hyperkeratotic plaques, okay? It's just these thickened hyperkeratotic, a lot of keratinocytes. So can you kind of think of what that would look like in your head? And plaques, it's a larger lesion. This really likes the flexural surfaces. So armpits, back of the neck, those are the two main areas. It can be in the groin and the lower abdominal folds. I have seen it widespread though. Sometimes you'll even see it over the bony prominences of the joints. I had this one young guy who had it widespread. I mean, all over his trunk, and it was all over. Another thing, superimposed acrocordons. Anybody know what that fancy word stands for? skin tags. So diabetics or pre-diabetics typically have a lot of skin tags. I mean, every one of us in the room is going to make a skin tag, at least one in their life, but diabetics and pre-diabetics tend to make them by the hundreds. So you may see that. So that's on the back of someone's neck. People will come in and say, I have just got this dirty neck, and I rub and I scrub and I just can't get it off. What is going on here? And that's what it is. Here it is in somebody's axilla, and again with a bunch of skin tags associated. Okay, treatment. Again, I think the most important thing is recognizing that this is basically a possible precursor to diabetes, or could be. So you want to treat that underlying hyperinsulin levels, and just emphasize to them that you need to keep a close eye on this for diabetes, the development of diabetes. Topically, the main thing I've used is your topical retinoids, or Retin-A, which kind of helps to get that cell turnover going a little faster, but it's really not that great. Weight loss, and then your metformin, which helps that insulin sensitivity. Okay, diabetic thick skin and limited joint mobility. We talked about that a little bit earlier. So again, the states of hyperglycemia leads to those advanced glycation end products, or the AGEs, which you have the abnormal degradation of collagen and the deposition of the collagen in the skin and to the periarticular tissue. So type 1 diabetics, about 30 to 50% of adults will develop this. So you're going to see this. It's probably the earliest clinical complication seen in children, type 1 diabetes, as they get older. And you see it more in people who've had diabetes longer and have not been in good control. Again, I can't emphasize enough that when you see this limited joint mobility and that thickened skin, they more than likely have some microvascular neuropathy, neuropathy, nephropathy, and retinopathy. So look for it, and I think the key thing is to prevent progression, you know. Okay, so clinically, again, this deposition is occurring deeper in the skin, not on top of the skin like acanthosis nigricans. So this is where you're just going to have a thickening of the skin, not on top, but all of it, and it's going to have more of a shiny, waxy appearance. Again, the hands and around the joints of the hands are where you mainly see it. Painless, difficulty moving their hands. So it's just a stiffness. It's not a true pain in the joint. So this is not an arthropathy or an arthritis or a destructive joint. It's just you've got that accumulation of the collagen in that skin and periarticular area, and it's just hard for them to move. There's something called the prayer sign that you may have somebody show you to see if they are suffering with this, and they are unable to do that. So the inability to approximate the palmar surfaces and interphalangeal joint spaces with the hands pressed together. I've got a picture of that. So they look more like they're praying rather than that. So again, if you see somebody who does this, what are you going to think about? Other than obvious they're diabetic and
microvascular.
Excellent. Okay, so the treatment is difficult. You know, once that process gets going, you want to get as tight glycemic control as you can to, again, prevent further progression. Some physical therapy to keep their range of motion going. Again, that strong association with retinopathy, peripheral neuropathy, and nephropathy is important. So you want to really, really emphasize to the patient to get that blood sugar under control so that we prevent further progression of all of these problems. Okay, eruptive xanthomas. All right, so we have states of insulin deficiency and hyperglycemia. This lowers how that lipoprotein lipase works. You get a buildup then of lipids, especially your triglyceride levels, and they can be up in the thousands sometimes. And this is kind of unrelated to the eruptive xanthomas, but how diabetics in general just have really high triglyceride levels. I had, a number of years ago, a young teenager who was a type 1 diabetic, and he was going on Accutane. I don't know if you guys have heard of Accutane. It's the big gun for acne. Well, it also will increase a person's triglyceride levels. So when I first checked his, you always get a baseline, kind of see where they are. They were elevated, but nothing, horrible. When he got on Accutane, oh my gosh, his triglyceride levels shot up, and it's kind of scared me a little bit. So I had to put him on a lipid-lowering agent while he was on the Accutane to keep his triglyceride levels down. So he could stop it after he was off of the Accutane, but while he was on the Accutane. Okay, so clinically, these eruptive xanthomas. So a xanthoma is basically a collection of that fat within the skin or the subcutaneous tissues. So there are different types of xanthomas. I don't know if you've heard of a xanthelasma. Anybody heard of that? That's kind of when people oftentimes will have elevated lipid levels and they get these kind of yellowish plaques up on the upper inner eyelids. The form that's really associated with diabetes is this eruptive xanthomas, and that's where they get these multiple small, firm, 1 to 4 millimeter papules that are kind of reddish yellow in color. Sometimes they can really group together to where they look like a plaque. Those are the areas it likes the extensor surfaces, pressure points, antecubital and popliteal regions. Usually they're not real symptomatic, but they may come in saying, what is going on with this? What's on my skin? I read an article too as I was doing this, and somebody they looked like these little wart bumps called molluscum contagiosum. And so they'd been treating them, and obviously it wasn't getting any better, and got to treat what it is. Okay, so they're usually asymptomatic. Sometimes they can be a little tender or itchy, and they may Kebnerize. Kebnerization is a term that means a rash tends to appear in an area of trauma. Okay, so on the skin. Psoriasis is another thing that tends to Kebnerize. So if you get a scratch on your skin, that rash tends to appear in that scratch. Sorry. So you might just kind of remember that term because we'll talk about that more probably in dermatology. So this is what it might look like. Again, a little hard to see, but multiple small, firm papules. If you could get a closer up look, it probably has more of a yellowish color to it. Things that are fatty or sebaceous gland tend to have more of a yellowy orange color with the skin. Okay, treatment. You have to treat that underlying hyperlipidemia, especially triglyceridemia, and the hyperglycemia to get that lipoprotein lipase activity back to normal. The surprising thing is these will usually clear quite rapidly in a month or two after you get that down to normal ranges. Okay, cutaneous infections. All in all, if you have a diabetic that's very well controlled, for the most part, they are not at too much greater increased risk of infections. But you have a diabetic that is in poor control, especially if they are in ketoacidosis, they are at great risk of developing infections. Plus their infections tend to be a lot worse than the average Joe, and they're harder to treat. Okay, so we know hyperglycemia and diabetes tends to cause an abnormality with how our white blood cells behave. Also, T cell function on the skin is compromised, and so that's another way that our immune system is compromised. Another thing too is that oftentimes, infections, especially the more severe infections, will cause your blood sugar to go up. So then it's kind of a snowball effect. You have to get that blood sugar under control. Okay. We do know that diabetics compared to non-diabetics tend to have a greater colonization of staph in their nose. And then there are certain infections that are just more prone to diabetes in general, whether they're under good control or not. And these are the ones. Invasive strep infections, malignant otitis externa, which is usually Pseudomonas. That's just a severe, you probably talked about that in ENT, a severe outer ear infection that can go very deep and even infect the bone. Necrotizing fasciitis, same sort of thing. It's a very deep skin and subcutaneous infection. That's oftentimes a group, or strep. Or erythrasma, is a more superficial skin, bacterial skin infection. Tends to like body creases, and that's more caused by Corynebacterium. And then there is a fungal infection with the strain Rhizopus, this rhinocerebral mucormycosis. This is a severe, deep infection kind of in the back of the nose, pharyngeal area that diabetics are more prone to. Again, these people are sick and will be hospitalized on IV antibiotics or antifungals. Okay, diabetic ulcers, very, very, very common. Approaches, a quarter of the population of diabetics. It is the most common cause of a non-traumatic cause for lower extremity amputation. Your risk for amputation in a diabetic is approaching 50% greater than in a non-diabetic. So, have to be careful. And it is the most frequent reason for hospitalization in a diabetic. It's a diabetic ulcer, foot ulcer. Okay, so various factors that encourage the development of these ulcers. Peripheral neuropathy, peripheral vascular arterial disease, and plantar pressure from foot deformities or callus formation. So we'll talk about these. Neuropathy. All right, so neuropathy, they don't have that protective sensation or the protective sensation of their feet. You and I, if we had a cut on the bottom of our foot, every time we walk, it talked to us. Certain diabetics who don't have that sensation, they don't even know it's there. They're walking on it every day, and it's progressively getting worse. They also lose function or function deeper in the tissue, in the dermis, which then decreases how much they sweat. And then their feet get extra dry, and anytime you have really dry, callous feet, you always get fissures, and there's a good portal of entry for bacteria. You also have, anytime we get a cut, it always tends to get a little red and inflamed around it, doesn't it? And that's part of the body's immune system. And so that it needs that to heal itself and to fight off potential infection, secondary infection. Diabetics, or diabetics under poor control, tend not to have that response as well. All right, so we know diabetics tend to have micro and macrovascular problems. Peripheral arterial occlusive disease is 4 times more present in a diabetic. And then you throw on top of that a diabetic who smokes, has high blood pressure, and has high lipid levels. They are just waiting to have problems with their arterial supply. And you have to have good blood supply for any wound to heal. Okay. The other thing too, kind of having to do with the vascular system is in the venous side, they tend to have a little bit more they don't constrict and dilate as well as others, and so they tend to have more vascular dilatation lower in the legs, so they have a lot more swelling and almost like stasis, venous stasis changes. And that really compounds how slow an ulcer can heal. Anytime you have an ulcer on the foot, or a sore on the foot, I'm going to go to an ulcer, a sore on the foot, the further away from the heart a wound is, the longer it takes to heal. So in you and I, if I say got a biopsy or something from the bottom of your foot, that's going to take probably 3 times longer to heal than if I got it from your arm. You compound a diabetic with no sensation, maybe no good blood supply, they have a lot of lower extremity swelling and edema, that just compounds how slow these wounds will heal. In fact, I had a gentleman, he was diabetic. He just, nicked himself on the dishwasher and had an ulcer form on his lateral calf, and he had horrible venous stasis. And poor thing, I saw him, I think 2 or 3 times a week for, I think probably 3 months, just because he lived by himself. He was quite obese and couldn't, take real good care of it. So I had him come in and I, wash it up and apply a new dressing and that sort of thing. So it just takes forever for these to heal up, even with good blood supply sometimes. So, okay, plantar pressure. Foot deformities are pretty common in diabetics. You have something called a Charcot arthropathy. Not 100% sure what causes that, but they think that just repetitive minor trauma or maybe even mini microfractures leads to this abnormal deformity in the foot. They will sometimes have things like, what am I talking about? Hammer toe deformities, where their toe kind of sits up like that. Anytime you have deformities like that, that allows a point of pressure. And as we age, the bones in our feet just tend to kind of settle, and there's always more of a pressure point on the bottom of the foot. I mean, you're always going to see that. But it's extra worrisome in a diabetic because that pressure callus is a place for an ulcer to start. Okay. Okay, so you tend to get diabetic ulcers are basically where you get skin breakdown, usually over bony prominences of the foot, especially over the toes. On the bottom of the foot, it's going to especially be over the metatarsal heads or the ball of the foot and the heel. Typically, there will be a ring of callus around the outer edge of that, painless. Again, if they cannot feel, don't have sensation, they don't even know it's there hardly. And again, you've got a massive wound, a portal of entry for bacteria. So here's some bilateral pressure over, diabetic foot ulcers. Okay, how do we treat or manage these? You obviously want to change some of the factors or improve upon some of the factors that encourage the development, such as you want to manage your blood sugar better. If they have a lot of swelling and edema and venous stasis changes, you might encourage wearing compression socks, getting their legs elevated up above the level of their heart as much as they can. If they clinically look like they don't have a good arterial supply, then you need to refer them to a vascular surgeon. Debridement with good wound care and dressing, offloading, and infection control. All right, debridement. This is where you remove all that necrotic dead skin around the ulcer. This promotes wound healing, the granulation tissue, which is that good, healthy tissue that's trying to regrow, decreases the risk of the infection. And once you know, if you don't take away some of that pressure around an ulcer, it's gonna take even longer to heal. So you have to get pressure off of that ulcer. There's different types of debridement: surgical, enzymatic, autolytic, where the body kind of produces, will help to break down that tissue. Surgical is the gold standard. That's just where you're gonna use a paring blade and just trim that down. Okay, dressings. I'm not going into huge detail. I mean, there are 80 gazillion different dressing options out there. I do believe, hopefully, last year they had a lecture that went through a lot of these, so I was not going to do that. Main thing is dressings. We used to say dry any wound out, you know, make it bone dry. Now they've changed their tune a little bit. They like it moist. They found that the exudate from the ulcers or any wound is oftentimes helps with the healing process. And so we don't want to completely pull that away, but we also don't want it completely saturated. And there are going to be some wounds that are more exudative and some that are more dry. And I would guesstimate that people who have a lot more of the venous stasis changes and lots of edema, theirs are going to ooze a lot more. So, let's see. So, the optimal wound dressing, it helps keep it moist, supports that autolytic debridement of that dead tissue, absorbs excess exudate that we don't want, that would kind of slow things down. Again, if you keep things too wet, it slows things down as well, slows the healing down. Protects that surrounding skin, and it can be easily removed and is cost effective. Tegaderm is probably a good place to start, unless if you just have a really heavy exudate. So again, hopefully we'll have more information about the various types of dressings. Do you talk about that much?
I don't do as much.
Okay.
Maria Jones may talk about some. They may have done it in Capstone, but I don't go through a lot of the dressing. It's not really in my training,
Yeah.
so I don't cover it.
I think, I was going with Vicki, going through the dermatology lectures, and there was one that looked like she did a lot of wound care and that sort of thing, so hopefully you'll get more of that. Okay, offloading. Offloading is basically removing the pressure from the ulcer, non-weight bearing. You have to take the pressure off of it for it to heal. There are different types or ways we can do that. Wheelchair and crutches, that's pretty convenient, but people probably aren't going to do it very well, or not as well as you'd like them to. Probably the gold standard is this total contact cast, and that is basically where they apply a cast and leave it on for, I think, a week or two. I want to say back in when I was doing my rotations, they called them moon boots or something like that. They actually use a plaster or now fiberglass or something like that. It enforces compliance. I mean, they can't take that off themselves. So it forces that it is time consuming. You have to reapply that. The other thing too is you have to make sure the person who's putting it on does it appropriately, because if you have, you know, an area that's really rubbing against their skin inside that boot, you could potentially form another ulcer. So that's the downside to that. You don't want to use it though when you really need to see on a daily basis the wound. If you've got severe ischemia, very severe abscess, osteomyelitis, you don't want to cover it up for a week and keep your fingers crossed. You can also use removable cast walkers, which is basically a walker boot. Again, that allows you to be able to take it off so you can see it, but again, how good will compliance be? If you've got a highly motivated person, they'll probably do it. All right, infection control with diabetic ulcers. You want to, if you are suspicious of an infection, secondary infection, you need to get a culture. And you always want to get anaerobic and aerobic cultures. But if you're not really suspicious of a secondary infection, you don't necessarily want to swab for a culture because it's going to grow stuff. You know, if we swab my skin, any of our skin, it's going to grow stuff, the normal bacteria. So I wouldn't just haphazardly culture everybody, but if you're seriously considering or worried about a secondary infection, then by all means. If you can get a tissue culture is optimal. However, that's when you get basically a biopsy. You send that tissue in for culture rather than just getting a swab and getting some of the discharge. My concern about that is you've got a poor healing wound to begin with, and then you're making another bigger wound. So I don't know if people really do that clinically that much. Yeah.
Could you use if you had to debride, could you use like what you get off of it to culture?
Probably not, because that's gonna be, that's not in the center of that ulcer, that's just that dead tissue. And I would probably try to get some of the obvious drainage from it, or if you can really get down deep in there, that's probably better than just kind of, swishing around up on top. Usually it's gonna be multibacterial, polymicrobial. Oftentimes they will grow anaerobes as well. Mild infections, your antibiotic of choice is just gonna go geared towards staph and strep. Gave you some examples of that or suggestions of that. If it's a moderate to severe infection, you need to go cover polymicrobial and your anaerobes, and these people are gonna be sick and more than likely receiving IV antibiotics. And you always need to work up for osteomyelitis where there's bone involvement. And then once you get your culture, you start with your antibiotic. Don't wait until you get your culture results. Start on something and then adjust it according to your culture results. Okay, so what's really important is educating these patients. I know that you have been taught that it's vital for you to observe a diabetic's feet every time you see them, but you need to educate the patients to examine their own feet daily. Some other things to talk to them about. Just gentle cleansing with soap and water, okay? Make sure they're doing that. Try to dry real good in between the toes. We don't want an environment where we could potentially get secondary fungus and things like that. So dry it off real good. Try also moisturization, very, very important. Because when you've got skin like that, that outer barrier of your skin is protective. When that is not as healthy, you are more prone to infections and things like that. So you want to keep that skin well nourished. I love CeraVe products. There's a new CeraVe ointment that is really good. I would have them put CeraVe on at least twice a day to their feet and lower legs. Avoid harsh products. Things like hydrogen peroxide, betadine, any of those astringents, rubbing alcohol. I hear all the time people just washing or cleaning their wounds out with alcohol multiple times a day, and I'm like, oh my God, how are you doing that? And it's just, when you have granulation tissue that's trying to heal itself and regrow, harsh products like that are only gonna not help. So just very gently, yeah.
A lot of my older patients will soak in bleach,
Oh,
and I find it to be fairly common because they feel like it's gonna clean their skin.
you know what? You say that. Probably a dilute chlorine.
That's what they do.
Yeah,
They'll
is
use
not
it
a bad idea, actually, because we recommend that all the time with atopics. People, kiddos with severe eczema, atopic eczema, and just to keep that bacterial load down. But make sure you emphasize, once you get that off, maybe rinse it off, and then moisturize, because that's gonna dry their skin out. So really emphasizing that secondary moisturization. Okay, So they need proper fitting shoes, pressure relieving insoles potentially. Protect their feet from the heat and the cold. When you are getting into a bathtub, or they are getting into a bathtub, have them check the temperature with their fingers where they can feel the temperature rather than plunging their foot into a potentially hot bath water. Heating pads, that's a no-go when you can't feel that heat and if it's heating too much. Never walk barefoot. You're just asking for a cut. If they notice any minor injuries, get to the doctor so that you can get things taken care of quickly. And core and callus removal, I think if they've got good sensation, they can probably use their home stuff, unless if you would disagree with me, Dr. Latassi. But if they cannot feel, then I think they need to have that done by a professional.
Patients have scared me at the amount of cutting they will do on their foot.
There's
So
a-
I always tell them, don't do it.
Yeah, well, and that's true. Again, I think, yes, you're right. There's a fine, I tell people all the time, there's a fine line between getting it down to a good level and then getting a little too deep.
Had a patient who had bad psoriasis on the bottom of her feet. She didn't have very good sensation, so she used scissors to cut the psoriatic plaques off of her feet. Because every once in a while I notice her limping, I'm like, what is wrong with you? Take them off, here's all these
What kind of
scissor
self-torture have
marks
you?
all over her.
With people like that, I know psoriatics tend to like to pick at their, pick that scale off, and I just try to encourage some kind of like a salicylic acid or something like that to more medically get that softened than them tearing it off where they can hurt themselves. I tell you what, do you want to take a quick break now, or do we want to plunge through? There's really not that much plunge there. Okay, I kind of thought that might be here. Okay, so these are skin conditions that we don't really know why or how they are related to diabetes. Necrobiosis lipoidica diabetic form. That is a mouthful, isn't it? Anybody heard of that one? Diabetic dermopathy, bullosis diabeticorum, granuloma annulare, and perforating dermatoses. All right. NLD, that's much easier. That's how I remember it, NLD. Dermatology has so many short, acronyms or, yeah, that sometimes I can't even remember what it stands for. So necrobiosis lipoidica diabeticorum, NLD, strongly associated with diabetes. If you see this on somebody, you always want to ask, are you diabetic, or could you have diabetes or pre-diabetes, and probably test for it if they say no. However, it's not a real common thing. You only see it in about less than 1% of diabetics. So, large percentage already have diabetes. Probably 2/3 of the people that have NLD already have diabetes. Another about 10% will eventually develop. 4 times more common in your female population, and tends to be a younger age. Mean age is 34 years. That may be a little bit younger with insulin-dependent diabetics. So this is where you get 1 to several sharply demarcated plaques, and that means you can tell very easily where that lesion begins and where it ends. Usually on the lower legs, the anterior shins. Initially it tends to be kind of a reddish to violaceous. Violaceous is kind of a purple color. And red, violaceous, red-brown, it's kind of varies. But these are going to be firm. Indurated means that it feels firm, okay? Papule or nodule, this tends to spread out, and that center becomes very scar-looking. Looks like a scar, atrophic, that's what that term means. It may even be depressed a little bit. Uh-oh, what did I do? I'm using my hands too much. I tend to talk with my hands.
It does this every afternoon. You have to wait for it to finish shutting down, and then we can start the computer start. But if you want to keep going, we have it on ours. And you
Oh,
can
okay,
still
yeah,
see
you can
it.
do that. Okay, so then, once you get that atrophic area kind of in the middle, it tends to look a little bit more brownish, orangey, yellow, and oftentimes we'll see the telangiectasia, those tiny little blood vessels. This is usually asymptomatic, but if you look at the picture of it, a person's gonna come in for that, wondering if it's cancer or what in the heck's going on. About almost a third of the time, you may get an ulceration within these lesions. Treatment is a little questionable. I would probably, thank you, if it's really not bothering them and they don't really care, they wear, slacks all the time and they don't really care that it's there, they just wanted to make sure it's okay, I would do nothing. If they're just like, I really want to try to improve the appearance of this, I would probably try a topical steroid, probably mid to high potency steroid, and you may even need under occlusion, meaning put your cream on, your steroid on, put a little thing of saran wrap around it, maybe pull up a sock and sleep like that at night, just at night. Now sometimes you can do intralesional steroids where you pull up some Kenalog and inject it into the lesion, several little areas, but you have to be real careful. If you get too much of that steroid, it can actually cause an ulceration there too. So I'd be a little bit leery. So ultraviolet light has been studied in this as well. And there's a picture of it. That's going to catch somebody's attention for sure.
I know it's not very common, but I think it shows up on boards, across
Does it?
the different
Right.
professions. I hear my ped endo friends talk about it more. I haven't seen it in adults, but they would deal more with the type 1 in a younger population than I do,
Yeah.
but.
I don't think I've seen it on one of my pants or panties, but yeah, if
It's kind
it's
of one of those favorite,
Yeah.
doesn't happen very often, but it's very diagnostic of
Exactly,
diabetes.
exactly. Diabetic dermopathy, this is your most common cutaneous sign of diabetes, tends to see it more in men over the age of 50. Thought to be, except we're not 100% sure, but thought to be kind of where they've had previous trauma, again to the lower legs. May be a little bit darker at first, and then will eventually fade and look almost scar-like. Asymptomatic, again, you may have resultant hyperpigmentation or lighter than normal skin tone with that scar appearance. No treatment is needed. And that shows more of the hyperpigmentation changes rather than the lighter hypo with scar looking.
Look for those on your patients at Good Shepherd that have diabetes. We've seen it on a few, so look for it.
Yeah,
It's a common skin change.
absolutely. Yeah, it's the most common. Bullosis diabeticorum is kind of an interesting thing. I had one patient, I don't think I've ever seen this clinically. I had one that we were kind of suspicious of, but we kind of then ruled it out. Rare, more common in males. This is when you get kind of an acute onset of blisters. That's what a bullous is, a larger blister. And it's going to be more symmetrical and no obvious history of trauma or explanation for that blister. Tends to be on the toes, the feet, or the lower legs. Every now and then it can be the distal upper extremities. But there's no redness, no sign of infection. Painless and doesn't itch. These will heal spontaneously, so no infection. I guess if I was seeing them, I might just, in a medical setting, help to drain that ulcer, not unroof it, but just leave it there so they're not getting after it and, go taking a pair of scissors or something like that. Sometimes though, once it's cleared, it's not uncommon to have kind of crops of this, down the road. And you always, the main thing is just be cognizant of secondary infection. And there's a picture, the bilateral. So again, if you see somebody with bilateral blisters on their feet or toes, and there's no good explanation for it. I was thinking other things on your differential. Contact dermatitis, you're going to have redness and severe itching usually with that. Sometimes you can get bullous formation with like a tinea or something like that, but again, you're gonna see more scale and redness and itching, and these are just blisters, you know, just kind of an odd presentation. Granuloma annulare. This has an association with diabetes. Again, we don't really know why. We don't really know what causes granuloma annulare. There are different patterns of GA. The more generalized or systemic form is what you see with diabetics. Right. So again, if you see what looks like granuloma annulare widespread, you might ask, are you diabetic, or could you be diabetic, or is there family history of diabetes, and you might test for it. So basically, say you've got a single lesion, you have one or more indurated, again, that firm feeling if you touch it. Skin color to reddish on the lower legs, I think they tend to have more of a violaceous, that purpley discoloration. Tends to enlarge, and that center, you have that central clearing. It looks identical to ringworm. But, again, go back to ringworm occurs in the epidermis. So with ringworm, you get redness and scaling and things like that. This occurs in the dermis, and it's just lifting up. So you don't have the scaling and the, well, you're gonna have discoloration, but you're not gonna have the scale. Now, when you have a more generalized form, it could be those textbook appearances where you have a larger central clear lesion, or you could have just a bunch of smaller papules, or a combination of the two. This rash tends, or these lesions tend to like bony prominences. You see them a lot on the back of the hands, wrists, elbows, ankles, feet. But again, in the more generalized form, you're going to have truncal involvement as well. So on the right is, yeah, you're right. Oh, excuse me. Is the more textbook where you have that papule that expands out. If you would look at that, you'd be like, oh my gosh, that's ringworm all day long. But again, no scale. And the thing too, this versus your NLD, the NLD tends to have that atrophic scar look to it, has more of a yellowish discoloration, where this doesn't have scarring. And then on the left side is just more the widespread papular granuloma annulare, which is more either a combination of both of those presentations, but widespread with diabetes.
How would you differentiate the papilloma effect from the eruptive xanthomas? Are they less yellow?
Oh, from the eruptive xanthoma? Yes, those are going to be much more yellow, the eruptive xanthomas. These are basically just skin color to a little bit pink to a little bit violaceous in color. But the more xanthomatous are always going to be kind of yellow. Okay. And perforating dermatoses. This is a kind of a group of disorders that is characterized by transepidermal elimination or spitting of collagen and other elastic fibers, okay? So your body is basically just kind of spitting out some collagen or elastin fibers. Curley's disease is kind of the term you'll hear for the perforating dermatosis that you may hear of the most. These are very itchy, hyperpigmented, they're going to be darker than the normal skin, and they have these central keratotic plugs. So keratotic plug is just, I don't know, does anybody know what keratosis pilaris is? Those little fine bumps that people get on their arms? It's like a really big version of that, except it's not necessarily associated with the hair follicle. Again, lower extremities, you're going to see this the most. Middle age, more often in black males. I think the key to remember here is you're diabetic with chronic renal failure on dialysis. I have always associated more with dialysis, so remember that. If you just have this funky looking rash that you're like, oh my God, what is that? And it's a, a long-term diabetic on dialysis, then think of that. No good treatment. You could use, again, some things to help, some topicals to help break down some of the rough, dead skin accumulation, but it's not gonna be fantastic. Maybe the corticosteroids, topical steroids. Light therapy actually could probably be very helpful for this, because people who are in chronic renal failure, because of the uremia, tend to be very itchy patients, and light therapy can be very helpful for just the uremia too, so. And there's a picture, so you can see it's hyperpigmented, these papules or nodules, and those hyperkeratotic plugs, those, just a collection of scale right in the middle of it. And that's it. Do we have questions?
I have a quick question. So the xanthomas, I've actually seen them like on the eyeball itself.
That is probably, I think that's probably something different. Sometimes, and I can't draw a blank on the name of it, but usually with just sun damage, pterygium, is that?
Okay, because I was looking it up online and I couldn't find anything else besides xanthoma.
Yeah,
So I'll look at that.
PTYR.
Okay.
That's just a normal aging sun damage change that you tend to get more on the medial aspect of the white part of the eye, and it looks very yellowish too, yes. But it's not associated with
Okay, no
hypertrophy.
association.
Could you kind of step back and say, okay, because I saw lots of skin, and we were like, do we send them to the dermatologist? A lot of the family medicine were like, they just kind of ignored it unless it became problematic from the standpoint of discomfort to the patient,
Right.
or it looked really ugly and they felt it was something else. So can you step back and kind of talk them through, patient presents, they've got this skin disorder, how would you approach it? What are we looking for? Do we treat? When do we refer? What's ugly and really needs to be?
As far as what
seen
we
by
just
somebody?
talked about here,
The more general ones, yes, except for an ulcer, outside the
Yeah,
ulcer.
yeah, yeah. Yeah, I think for the most part, well, let's go back, let me look at your, can I do my
Yeah.
number on that? Acanthosis nigricans, you're gonna address this, unless if a person is just like, I want this to be gotten rid of, and even a dermatologist isn't gonna probably get rid of that, but just emphasizing, address what's causing it, make sure you're evaluating them for pre-diabetes and get that under control.
Are you more worried about the amount of skin that's covered with any of these? Is it the amount of skin? Is it where it shows up? Is it more the
It's probably more how much
presentation?
it bothers them,
Okay.
because you got all kinds of different people, and in some, that NLD, that picture of that would be terrifying, and, in others, it'd be like, I just wanna make sure it's not cancer. Everybody's gonna present differently. That's why I'm saying with that one, you can always refer, but if you've got a pretty good idea of what it is, you can just give them reassurance, to get definitive with any of these, it's gonna require a biopsy. But then you're like, do I wanna put a wound in somebody's lower shin if I really don't have to? I think the one time is the bullosis diabetic corn, because there are other bullous diseases that can occur that are more autoimmune. So I would probably refer that on to a dermatologist, because they may want to, unless if it's just straightforward, but I probably would refer that so that they could maybe get a biopsy. To look for these other bullous disorders, you usually get 2 biopsies, one at the edge of the blister, and then one kind of peri around the area to look for direct immunofluorescence, to look for the the antibody within that skin, so. Everything else, I
Is there any
think.
problem in primary care going ahead and biopsying that and waiting to see what it comes back before referring, or would a dermatologist rather do that